Thank you, Ruth. It's always nice to come and talk to the Scholars Program. I'm not a formally trained ethicist. You may wonder why I'm talking about advanced directives, and the main reason is because I have to deal with these issues basically every day in my practice with all the patients that I take care of. And it's actually not an issue that's just germane to geriatrics, but to all of patient care. It just so happens that geriatricians, probably more often than other physicians, are actually dealing with end-of-life decisions, or are more frequently dealing with end-of-life decisions. The two handouts that you have, the one that's titled Advanced Directives is the handout that was used for last year's American College of Physicians course, in which we discussed this in preparing physicians to take their board exams. The handout that's called Ethics in the Practicing Internist that Henry Perkins has developed is going to be incorporated into that course this year. You have the hot draft. It was just available as of this weekend, and it's going to get incorporated into this other handout. The focus is going to be primarily, though, on advanced directives, and what I'd like you to get out of this this morning are basically three things. The first is to try to understand some of the basic ethical concepts of autonomy and beneficence in guiding decision-making with patients in terms of what the physician's responsibilities are in interacting with patients. I'd like you to begin to have an understanding of the constructs of competence and the difficulty that comes in assessing competence. And then finally, and what we'll spend most of the time doing is talking about the uses and limitations of four forms of advanced directives. Directives to physicians. Let me get to this slide here. Directives to physicians, also known as living wills, durable powers of attorney for health care, guardianship, and then finally the use of so-called do not resuscitate orders, which I think is actually an unfortunate term. Okay, so let me back up here a little bit. What are advanced directives? Advanced directives are expressions, and these expressions can be either written or oral, made by competent patients, and I think it's important to remember the term competent, as to the type and duration of care they would like to receive in the event that they become unable to participate in decision-making regarding their own care. So these directives only kick in or only become effective after a person is unable to speak for themselves or express their own preferences. Obviously, if I went to my physician or I became ill, as long as I was able to speak for myself, I would be the person who should have the only authority to make decisions about what I would want for myself. And if I had dementia and had been robbed of the ability to do that, then either I should have made some kind of expression ahead of time to my family, telling them that, these sorts of things happen. If I become demented and I have a heart attack, don't put me in an intensive care unit, just let me go. Or I should have assigned decision-making authority to another family member or whoever I chose through a power of attorney for health care. So that's what those documents are intended to do. It's important to remember a couple things. First of all, decision-making is fluid. That is, decisions may change based on changes in a person's condition. I may feel one way about my state of health now, but if I developed some type of chronic illness and became debilitated, my view about what I would want to sustain my life may be different. It's also important to remember that it's very, very difficult for people to actually anticipate all the circumstances under which they may lose their health and decision-making capacity. So, for example, if if I had arthritis and was homebound or bedbound because I couldn't move, but I still had my mental faculties, I may be willing to accept that kind of an existence, but there are other circumstances where I might not. For example, if I had a stroke and was also bedridden but did not have my cognitive abilities, that I might find unacceptable. Okay, well, let's talk a little bit now about some of the ethical concepts that underlie getting these advanced directives in place. The first one is the principle of autonomy, and this is actually the principle of self-determination. And as long as a person's wishes do not interfere with the liberty of others, a person should be free to define their own notion of what is good for themselves, what is a good life, or what is a good death. And they should likewise be free to pursue the care that they wish to have in their own way. In other words, if somebody tells you that they don't want to have chemotherapy for the treatment of a cancer that is likely to kill them, and they understand the ramifications of that decision and it's not going to influence anybody else, they have the right to choose for themselves to forego that treatment. Okay? Now, there are some limits to autonomy. If a patient's wishes come into conflict with a physician's own guidelines for ethical care, then you do not have to respect the autonomy of the patient. For example, and what I have listed here on the handout is the question of assisted suicide. If a patient asked me personally to help them die, to actively kill them, I couldn't do that as a doctor. And I would tell the patient that, I would not be able to fulfill that wish for them because it would be in direct conflict with the things that I believe physicians should be doing. That's different from basically standing out of the way and allowing a disease to take its natural course and keeping somebody comfortable. If there is something that the doctor just cannot abide by, then what the physician should do is inform the patient of that and then get somebody else to provide the care, basically resign from the case and get somebody else in place. Now, autonomy can also come into conflict with some principles of justice, and if a person's wishes and use of resources deny resources to other people so that they don't have access to care, that may not be justifiable, and their autonomy may not be respected under those circumstances. Now, one of the other concepts that you have to take into account when dealing with patients is that the concept of beneficence, and that it is assumed that doctors only pursue those treatments that contribute to the well-being of their patients. You're not going to undertake anything that you don't believe up front is going to actually help the person that you're looking after, or helping look after. This requires some fidelity, and that is that no patient may be put at risk or harm for the benefit of other people. Okay. Anybody have any questions about the concept of autonomy? Okay. Well, let's move on to competence. And remember that advanced directives are expressions that are made by competent people. And a competent person has the right to decide whether or not to accept medical care. That's the example I gave you of somebody who's competent, maybe having a cancer and choosing to forego chemotherapy. They have the right to do that. Now, it's important to remember that competence is a legal construct, right? It is not a medical construct. And an adult is presumed competent under the law until they are found incompetent in a court of law. For example, a psychiatrist cannot declare somebody incompetent, but a psychiatrist can provide evidence that the person has compromised decision-making ability and that they may actually be incompetent to make decisions for their well-being. As it turns out, there are no criterion standards for assessing competence. This is a very loose sort of thing. And a person's ability to make decisions may depend on the complexity of the decisions. So For example, for something as simple like feeding, if you talk to people about whether or not if they couldn't eat and feed themselves, if they would wish to have tube feeding to be kept alive if they were in a coma, a lot of people know or really understand what it means to be hungry. And they don't, if they were in a coma, they think about the fact, well, you know, if I'm hungry, I know what that feels like. I wouldn't like that. So yeah, maybe I would like to be tube fed. And people, it's very interesting to me when you talk to people about this, how often that seems to come up in terms of understanding that. I can give you an example. We had a patient with prostate cancer on our home care program who was wasting away. And both he and his caregivers wanted to be able to nourish him and hydrate him, even though they knew he was dying and he was on a hospice program. So we made the decision to go ahead and have a gastrostomy tube put in place. Something which is probably futile, but it was something that the patient and their caregivers wanted. So we respected that wish and had the tube placed, and the gentleman only lived for 2 or 3 weeks following the placement of the gastrostomy, but that was a value that they held for themselves and something that we acceded to. So for simple things, you know, people can be actually mentally quite compromised, but they may be able to understand enough to be able to make decisions for themselves. And again, I use feeding there as an example. Now, there are other decisions which may be much more complex. I actually think it's very difficult for most people to understand what it is like to be a patient in an intensive care unit, to be, you know, what it actually feels like to be on a respirator, to have a bunch of IV lines, and to be getting therapy in an intensive care unit. And the same person who may be able to make a decision about feeding may not have the wherewithal for a variety of reasons, illness or whatever, that would allow them to make a competent decision about more complex forms of care. Okay. So when you are talking to patients and trying to determine whether they're competent, you have to follow some general guidelines. And basically what you want to be able to determine is whether or not a person is able to actually evidence a choice, if they're able to make a decision about what it is they would like to have done for themselves. And there are several components to that. The first component is that the person must be able to understand the relevant information. So like, again, contrasting feeding versus ICU care, you know, when you talk to somebody about eating, they may have an easier time understanding that versus what it's like to have a tracheostomy placed or be put on a ventilator. And they also must be able to discern between different type of treatment options. So they have to have an intact memory and an ability to understand the meaning of the information if they're going to understand the information. And the information must be presented in terms in which a patient is likely to understand. So, you know, again, it makes no sense if you have somebody who's just got a grade school education to walk in and use medical jargon to try to explain things to patients. So the person must be able to understand, but the information has to be presented in such a way that they can understand. The person must be able to appreciate their own situation and the consequences of the choices that they're making. Part of this is acknowledging that they in fact are ill and have a problem that needs to be treated. They have to understand the consequences of accepting or declining treatment, you know, what may occur if they choose not to do something. If I choose to have chemotherapy, I may have some side effects from the medication. But on the other hand, my cancer may regress and I may live longer, and it's important for me to live longer. On the other hand, they may say, well, I may live several months longer, but my quality of life may be compromised further by the chemotherapy, in spite of, and I'm not willing to accept that because I want, even though I have a short time, I want it to be optimal time, therefore I choose not to do that, even though I recognize my life may be shorter. Those would be the kinds of things that the person would have to be able to demonstrate to you in that kind of a situation. And the person also has to have some appreciation of how likely these consequences are. Is it a remote possibility or a common problem that a certain side effect may occur following a given treatment? The person has to be able to manipulate the information rationally. They have to logically be able to compare the benefits and the risks of these various treatment options that they have, and be able to express for you in a reasonable way why they have made the choice that they have. And then finally, the person ought to be able to communicate a stable decision. Even if you have somebody, let's say, who has some dementia, if you pose the same question to them on repeated occasions and you get a consistent answer, they give you the same answer each time given the same evidence, even though they may not remember that you spoke to them about this before, they may be showing that they're able to make these decisions in a reasonable way and may be competent actually to make those decisions. Okay. Now, if you have somebody who is frequently changing their mind and there doesn't seem to be an underlying rationale as to why they may be doing this, that in itself may be supportive evidence for some impaired decision-making ability. Okay. So those are the four things. And what I do, maybe not quite this formally when I'm talking to people, I will write notes in the medical record, either in the outpatient record or when I have somebody hospitalized, attesting to what the person's abilities are. Again, I can give you a very concrete example of this. I currently have a 93-year-old gentleman in the hospital who has a profound dementia, and he cannot live on his own. He lives in a personal care residence, and he was admitted with weight loss and abdominal pain. He'd actually taken to bed and wasn't eating. And I don't think it would be in this gentleman's interest for him to undergo cardiopulmonary resuscitation. I also don't think that this gentleman has capabilities, based on my past experience with him and having assessed his mental status, to make that decision. I don't think he understands what it means, and I don't think that he would understand the ramifications. I also believe his chance of surviving CPR is actually very low. So he has a niece who has his power of attorney for health care, and I spoke to her about these decisions. But in my note, I clearly documented that my belief that this gentleman was not competent to make the decision and the reasons why, under these circumstances, I was speaking to his niece and not to him about a decision to withhold resuscitation if he had a cardiac arrest. Okay. Now, any questions at this point about competence?
The way you define competent is being very competent unless declared incompetent in court.
Uh-huh.
When you spoke to the niece, would she have had to go to court to obtain
No, because this gentleman had executed a power of attorney for health care, so that when he became incapable of making the decision-making authority transferred to his niece.
Feeding, having a feeding tube, does that lengthen life? Or if you said the gentleman didn't live more than a couple weeks after you did that, you could keep someone technically alive forever with the tube, or most of these
No, it depends on what the underlying illness is. All right, the example that I gave you about the man with prostate cancer, I don't think that feeding made any difference to his length of life. You know, maybe it extended it a week or so because he didn't get dehydrated as quickly. but his family had the value of wanting to continue to feed him, and he wanted that. So we, even though we felt that that was futile, we went ahead and did this. Now, there may be other situations where, let's say somebody's had a stroke and they don't have a progressive illness like a cancer. If that patient had expressed the interest ahead of time that under circumstances like this they would want to be fed, or if their family who was making decisions for them wanted to do that, then that person could be kept alive for a very long time because of the provision of water and nutrition.
Would that be at all looked at as a quality of life, that particular level of tube feeding or not?
Yeah, but that's, yeah, I mean, it certainly is a quality of life issue, but quality of life is in the eye of the beholder.
Well, that's what I'm saying, right?
Right.
That could have been the next one.
Right. So, you know, it has to do with what the patient and their family or the people looking after them want for them. I mean, if a family, you know, you bring these issues up and the family says, well, what would you do? And I don't like to impose my wishes on other people, but I'll be happy to let them know what I think. And then they can make a choice. And I feel that my role as the physician is, again, unless this comes into conflict with my own standards for ethical care, is to try to be supportive and you know, accede to these wishes. And there are times when I disagree with the choices that my patients make. Okay, this just summarizes that, again, competence varies with the complexity of the decision that has to be made. I mean, there's some things that I'm perfectly incompetent to make decisions about, like, you know, what to do with my income taxes. You know? Okay, well, let's move on now to the various types of advanced directives. And there are five. There are no ideal directives, but one of the things that directives should be able to do, they should be unambiguous. They should be very clear as to what the person's wishes are, their intentions. They should have some flexibility. They shouldn't be very narrow. In other words, you wouldn't want a directive that says, if I'm in this circumstance, this specific circumstance with this particular illness, then do this. And it doesn't speak to a broader range of other activities. It should be documented. And this actually falls through the cracks an awful lot. Somebody will, you know, make a living will, but then they don't tell anybody about it. They don't tell their family. They don't give a copy to their doctor. They don't put it in the record. It needs to be available. And this is also something that can fall through the cracks. I ask my patients to give me copies of their advanced directives. I keep a copy in my record in the office, and then when they come into the hospital, I duplicate that in case the person fails to bring it to the hospital with them, or their family fails to bring it with them, and then we make sure that that's in the record and it's clearly known. And the directive has to be executed in such a way that it's enforceable. It has to be legally effective. And there are some guidelines in each jurisdiction, in each state, as to the qualifications as to what is a legally effective document. And we'll talk a little bit about that. Okay, so living wills, again, a directive to physicians these are really called directive to physicians, and then the sort of more common term is a living will, but the proper term is directive to physicians. And again, these are a declaration, again, by a competent adult to withhold or withdraw life-sustaining therapy when a medical condition is irreversible or incurable. So when a person gets into a situation that there's no hope of recovery, then the living will becomes effective as the document of the patient's wishes for what they would like to have. So, I mean, again, the way that I put this to people when I'm talking to them, I said, I want to know what you would want for yourself, if you were hopelessly ill and needed to be, let's say, kept on machines to be kept alive? Is that something that you would want for yourself? And some people say yes. They would like to be kept alive no matter what. And some people say no. It really is up to the wishes of the person. And also, people's responses also get framed by the way the information is presented to them. Okay, so what are some other features of them? A person may execute a living will, then change their mind later on, and they may revoke it at any time as long as they're still competent to do so. It's important to remember that a legally effective directive takes precedence over the wishes of others. So if I have a patient who's in the hospital who has these wishes documented, and the daughter who lives out of town comes in and says, no, we want this for Dad, you know, you do this, this, and this, that doesn't cut it. It's what the person wrote down for themselves, and that would take precedence over what the family's wishes are in that circumstance. That should be binding. You have to make sure that you've met those requirements, that you've documented that the person is irreversibly and terminally ill. Irreversibly ill or terminally ill in the record in order to have that directive to take effect. But again, if somebody else comes in and says, no, we want to change this, it's the directive that has precedence, because that's the person's own expressions of wishes. And then the form that these directives takes varies between jurisdictions. So if you're living or practicing in a given state, you need to be familiar with the law regarding directives in the state in which you practice. Some of the features of the directive to physicians in Texas, defined under the Texas Natural Death Act, is that the irreversible condition must be documented by 2 physicians. So if somebody comes into the hospital and you believe they're terminally ill, you can write a note as the attending physician, but then you need to ask one of your colleagues to actually document that as well. When these directives are assigned, when a person makes one out, there have to be 2 witnesses, and the witnesses may not be related to the patient, and they have to have no interest in the estate of the patient. They have nothing to gain by the person's death. The doctor may not witness the directive, so the healthcare provider cannot do that. And importantly, this directive must be executed voluntarily without coercion. This must be a decision that the person themselves makes. Also, this is something that you come across, or I come across in my practice. You talk to people about this. There are some folks who simply do not want to put something like this in writing. And their family thinks it's a good idea, the doctor thinks it's a good idea, but the person says, no, I just don't want to have anything like that around because I don't know how I'm going to feel under those circumstances, and I don't want people to withhold something that might help me simply because I've got this piece of paper in place. And there's some browbeating that goes on the part of the family. But under those circumstances, a person should not be coerced into filling out something that they do not wish for themselves. Okay. Now, it's important to remember, and again, I have direct experience with this. When people come in and they see a living will on the record, when they come into the hospital, people, or some physicians or the healthcare system may feel that this person isn't going to get the full court press. We don't have to do absolutely everything that we want that needs to be done for them. And they may back off and not pay as much attention or care as much for the well-being of that individual. And I've seen this in the hospital. I hope that I'm not guilty of that, but I might be. I try not to be. And patients have directly expressed this to me as well. I have another demented patient who's homebound, who I talked to the daughter about putting a directive in place, or getting her mother to put a directive in place, or putting a do not resuscitate order on the record, and she didn't want to, because she believed that care would be withheld inappropriately. So, there are a number of things that people can, still benefit from, even though they are compromised. I mean, you can be terminally ill and still have a pneumonia, and not wish to die from the pneumonia, and get treatment for the pneumonia, recover, and still go on and have several weeks to months of life left. So you may want to have a trial of therapy. And it doesn't mean that you stop caring about these people simply because they have directives in place. And this is one of the, this is a problem that will come up in the hospital and other settings. Now, again, as part of these directives, people may express their preferences for different types of treatments. We've already talked about nutritional support, and at the VA we have a separate document that's called Treatment Preferences that goes on with the directive to physicians, where we talk about whether or not a person would want nourishment. We talk specifically also about blood transfusions. And again, I can give you an example of another gentleman with prostate cancer who had anemia and felt weak because of his low blood count. And both he and his wife decided that he would like to have transfusions, because after he got transfused for a week or two, he felt better and had a little bit more pep and energy. And we transfused him several times before he died, again, because he requested this. Antibiotics, I mentioned in the example of somebody has a pneumonia and you want to get them over an intercurrent illness. And then, trials of therapy. For example, there are lots of people who have told me that, they would like to be maybe put on a ventilator for a day or two, and then if it looked like they were not going to get off the ventilator, if things were getting worse, then it would be okay to go ahead and stop that. Okay. All right. Any questions about directives to physicians, living wills? Okay. Let's move on now to powers of attorney for health care. And in these circumstances, again, a competent individual assigns healthcare decision-making authority to another. One of the nice things about this is that you can be really compromised mentally, but still make a decision about who you trust to make decisions for you. And, I couldn't imagine a circumstance, unless I was robbed of my ability to speak, where I would be so cognitively impaired that if my wife was still around, that I wouldn't want my wife to make decisions for me. And typically when I'm seeing people in the office or out in their homes, even very compromised people, when you ask them a straightforward question like, if you were unable to speak for yourself, who would you want to have speak for you? They will turn and point to their spouse or their adult child as the person that they want to have to make that decision. And so I think that very compromised people are actually competent to make these decisions, to put in place a power of attorney for health care. They may not be competent to make it out a directive to physicians, but I think they're probably competent to to sign a power of attorney for health care. Now, it's important to remember that a power of attorney becomes effective only when the person themselves becomes incapacitated to communicate their wishes to others. So as long as the person can understand the decisions, they're still competent, and they can communicate those wishes, then they're the ones you speak to. If they either cannot understand, if they're not competent to understand, or they cannot communicate. If somebody, again, has lost the ability to speak and isn't able to write, or in some other way let people know what their wishes are, it's only at that point that a power of attorney becomes effective and kicks in. Now, having a power of attorney means that you've got somebody else making decisions. And ideally, you would like to have the surrogate know what the wishes of the patients are before a crisis intervenes. the most trying times are when you're in a crisis situation and nobody knows what the person's wishes are. And a surrogate decision maker is required to make the same decisions as the patient would make if they were capable of doing it themselves. So one of the problems that comes up is that patients and their surrogates often disagree. So, you know, I may wish something for myself and my wife may disagree. She may not, she says, I don't agree with that decision. What my hope would be is that even though she disagreed with it, she would fulfill my wishes, that she would make the medical decisions based on what based on discussions that we had had, and would act and make those decisions as I would make those decisions for myself. This often does not happen, where the family member or whoever the surrogate decision maker is acts in what they believe is the best thing to do, but in fact it is in direct conflict with what the person themselves would have wanted for themselves. So, you know, when you have a power of attorney for health care, it's very important that the patient, the person making this thing out, goes ahead and discusses what they want for themselves with the people who are then going to be their surrogate decision makers. So it's not enough just to have this in place. People need to talk about their desires and make sure that those are clearly communicated and then documented. And this is something that's actually very, very tough for people to do. Nobody wants to talk about circumstances of their death and issues related to dying and the different things that may go on around that. Let's see. Okay. Now, let me back up here a little bit. There's one other point about surrogate decision makers. Most people do not have powers of attorney in place and have surrogate decision makers. It's just not pervaded the population as something that people have for themselves. Now, in Texas, if they're, you know, for emergency care or urgent care, there are certain first-degree relatives who may consent for care if the patient is incapacitated. So, for example, if there's an automobile wreck and a person's knocked unconscious and they come on in and they don't have a power of attorney for health care, then their spouse, a parent, an adult child, or a sibling may make decisions for that person in their behalf for emergency care. Okay. Now, what if a person doesn't have any people who can speak for them? They don't have any family, they don't have any friends that they would trust. Then the alternative is guardianship. And this is put in place for an incompetent person who cannot assign surrogate decision-making authority for health care through a power of attorney because they don't have somebody. Either they are so incapacitated that they cannot express who they would want to be their health care agent, or they have no one to go ahead and assign this to. And again, I can give you an example of an elderly woman who lived by herself here in town, never had any children, was widowed, had a few friends, but was profoundly demented and actually became an Adult Protective Services case, recalled. And she had to have a guardianship put in place. And a granddaughter who lived out in California eventually came forward and agreed to serve as a guardian for this woman at a distance. This is a lengthy legal process. It takes several weeks to go ahead and get a guardianship in place. And what is done is that the person has a advocate, a guardian ad litem, put in place who's an attorney. It's the attorney's responsibility to act as an advocate for the person. They then get medical evidence, generally a letter from a physician who has assessed the person as to what their decision-making capabilities are. and then finds out, who the, if there is any family. And then this information is brought before a judge in court, in probate court, and the judge makes a decision about whether or not the person is in fact legally incompetent, and then requires a guardian to look after them. This can also be an expensive process, taking $1,000 to $2,000 to get into place, and it's not a happy thing to go through, especially if you have a patient or who's let's say demented and doesn't want to have anything to do with it and is fighting it tooth and nail, but is obviously putting themselves and other people at risk out in the community. And again, the doctor's role in all this is to provide some objective data about what the underlying illness is and what the person's decision-making capacity appears to be. Okay. All right, we're going to talk a little bit now about do not resuscitate orders. And by way of background, I want to talk a little bit about the Cruzon decision. Nancy Cruzon was a woman who was in a chronic vegetative state and who was being tube fed to be kept alive. And the family wished to have the feedings withdrawn because they felt it was futile, and the state disagreed. But in fact, the courts found in favor of the patient and the family. And Nancy Cruzon was a young woman and had not expressed, in clear terms yet, or hadn't really thought about this, as you wouldn't expect most people in their 20s to do, about what they would do if they found themselves in the kinds of circumstances that she was in. And basically what the decision upheld was that patients have the right to refuse or discontinuing life-sustaining care, and this right extends to comatose incompetent patients through, and the decisions get made then through their family or surrogate decision makers, and that tube feedings are not distinguished from other forms of medical therapy in situations like this. It's a treatment, and that you're not doing something unethical by withdrawing food and water for these people. And the same kinds of things applies to other kinds of therapy, including cardiopulmonary resuscitation. And cardiopulmonary resuscitation is a special form of therapy when somebody's heart stops or they stop breathing. They get chest compressions and mouth-to-mouth resuscitation in an attempt to keep them alive and until whatever the underlying problem may be corrected and to pull them out. Now, unless otherwise stated, if you come into a hospital, it is assumed that you will receive cardiopulmonary resuscitation if you are found, unconscious without a pulse or respirations. And the decision to withhold and not to do CPR is based on whether or not somebody feels that it is futile to go ahead and provide it. Now, the vast majority of do not resuscitate orders are based on a doctor's assessment of what futility is. And the problem with this is that a doctor's assessment of futility may vary. I may think that something's futile. Another person, another MD may look at it and say, and I say, like, a treatment that has a 1 in 20 chance of success, I may regard as futile. Another doctor may look at that and say, hey, it's got a 1 in 20 chance of working. It's worth the effort. Let's go ahead and provide this. The point here is that futility should be patient-based, and that is that undergoing cardiopulmonary resuscitation would not achieve this person's personal goals as they would express it, given the given information about what would be involved. Let me give you an example of how this might work. It turns out that if you're in the hospital and you suffer a cardiorespiratory arrest and you go through resuscitation, you have a 1 in 6 chance of surviving that and being discharged from the hospital. That's not to say that you survive that at the same level of function as before the arrest, but you've got a 1 in 6 chance of pulling through. That means 5 times out of 6 you're going to die in the hospital if you have a cardiac arrest and go through CPR. The odds are actually lower out in the community. In places like Seattle, which have very good ambulance services and the whole community is trained in CPR, you hear statistics of like 40% survival for out-of-hospital arrest. That's not true in all other cities, and I'm not sure that it's really true in Seattle. I'm not sure that I'm still skeptical about that number. But other cities, you hear numbers like a 1 in 20 chance of survival. Certainly by the time you call an ambulance, unless there's somebody in the home who knows how to do CPR, with a typical response time of about 10 minutes, a lot of damage could have been done if the person's heart had really stopped. For people who live in nursing homes, the chances of survival are even lower. They're like 1 in 100 because of underlying problems that have put them into the nursing home. So, when I talk to patients, and I do talk to them a lot about this, typically in the home care program and in the homes, I quote them these statistics. A 1 in 6 chance if you had an arrest in the hospital, a 1 in 20 chance is the number I typically use in the home. And I sometimes think that's a generous response given some of the underlying conditions that these people have. And given that information, the patients then tell me what they would want for themselves. And we have some people who say, nah, if that's what it's going to be like, let me go. And then there are other people who say, yeah, I'd like to have a chance. I'd like to undergo CPR even given those odds that you quoted to me. And what we then put on our care plans for the home care program, we have a separate line that says resuscitation status. And if the person says that they do want to have a trial of CPR, so the patient desires a trial of cardiopulmonary resuscitation, it's directly reflected in the chart. And if they say they don't want that, then we put a note in the chart that says do not attempt resuscitation. And we're very specific, so we withhold CPR, do not intubate, and withhold mechanical ventilation. One of the other things that we do then is I send a letter to the EMS service and tell them that there's a person who has these people also usually have living wills in place, that they have a directive to physicians in the home, and that they have expressed a desire not to undergo cardiopulmonary resuscitation. I don't say anything about what their medical conditions are because that would be a violation of trust and their right to privacy. But if the emergency medical service then gets a call about this person, it comes up on the screen that they've got a directive in place. The dispatcher sees that, and that they're to call the medical director for EMS. The medical director for EMS would then call me and ask me what's going on with this person, and we would talk about it, and then that's one way to keep CPR from actually happening. Sometimes you have these orders in place, and CPR gets done in spite of what decisions have been made because of the circumstances under which the arrest occurs. They tend to be very hectic situations. Okay. Well, what are the guidelines that a doctor needs to follow or ought to follow in order to put one of these orders in a chart? First of all, like I said, unless otherwise stated, consent to administer CPR to the patient is presumed. A doctor should discuss cardiopulmonary resuscitation decisions with the patient in advance. This should not be something that you talk about in an urgent situation, or you don't call the family up and say, Mr. Jones looks like he's fixing to go. What do you want us to do? That's inappropriate. The surrogate decision makers, again, should make decisions based on the patient's interests or in the patient's patient's preferences, or on the patient's what they believe are the patient's best interests. And again, their view of what the patient's best interests, given the same information, may vary from what the patient would have wanted. Um, a doctor is obliged to follow a competent patient's wishes regarding CPR. So if a person tells you they want CPR, even though you don't think it's worthwhile, you are obliged to follow that. And I've had a number of people who, if I was in their shoes, I do not think I would want to have cardiopulmonary resuscitation, but they say they would like to have a trial of this. In my heart, I know that when it comes to it, they will get it, and it probably won't work. But that's what they wanted for themselves. So we go ahead and honor those wishes. Okay, now futility is an indication for withholding CPR, but again, the definition of the futility depends on what the patient's preferences are. This was quite striking to me when I talked to this gentleman about it. This is a man who's got very, very bad cardiac function and has severe congestive heart failure. And he's been, bless his heart, he's been stable for the last 2 years. I would never have thought that, given as bad as his heart is, that he would live this long. And when I talked to him about this, I said, I said, if you had a 1 in 20 chance of surviving, would you want it? And he said, yeah. I said, what about 1 in 100? He said, you bet. What about 1 in 10,000? He said, sure, I'm going to be that one person. He just really felt that any chance that he had to live, he was going to be the person who was going to survive, which is an underlying personality characteristic and an underlying value that he has. And even if there's just a scintilla of hope, this man wants to undergo whatever it takes to get to live another day. Again, I disagree with his decision, but we are honoring his wishes, and if he ever has a cardiac arrest, EMS will get called and he will get the full court press. Will he survive it? I don't know, but I wouldn't be surprised if I get to see him the next day following this event. And then these do not resuscitate orders or do not attempt resuscitation is actually what I write, should be documented in the patient's chart along with a progress note that documents the discussion with the patient and their decision makers. And too often what you see is just a DNR order and no documentation of the discussion with the family. And again, these are not simple things to talk through with people. And what the note should describe is what the underlying condition is, why the doctor thinks it's not worthwhile, what information was communicated to the family and what or the patient, and then what the patient's wishes are, and then the action that you have chosen to take because of that. And that should be the standard. Does that always happen? No, but that's what should be taught, and that's what should be what we shall be working to improve as medical educators. Okay, well that concludes the comments that I have. Just to sum up, we've talked about some of the ethical principles and talking to people about end-of-life decisions and advanced directives, specifically autonomy, beneficence, and competence. And then talked a little bit about the different forms of directives, directives to physicians, powers of attorney for health care, a little bit about guardianship, and then finally decisions to withhold cardiopulmonary resuscitation. I'll be happy to take any questions.
I want to ask if there are any studies working on the predictors for how these patients are going to answer, and if there has on their educational videos telling them what the outcomes would be.
Yeah, there are studies. I mean, there was one. The most recent one that I actually think is quite helpful is in the New England Journal of Medicine, which was a clinical trial of presenting quantitative information to people. Most people, when you talk to them about CPR, they assume that it's going to work. You see all these emergency medical shows like 911 or Emergency, which are these very compelling, dramatic demonstrations of these emergency services getting put in place. People see that and they have the lay belief that this stuff works most of the time. When you actually present people with the data, with the numbers, based on clinical studies, they say, oh, well, you know, I didn't realize the chances were that poor under those circumstances. I want to change my mind. I do not wish to have this, and please withhold it. Don't provide cardiopulmonary resuscitation for me. And a fair number of people do change their mind. I don't remember right off the top of my head what those numbers are. But the people who do that kind of research have developed you know, patient information videos that I imagine are available if you wrote to the authors.
You don't use those issues personal.
Yeah. No, I talk to the patients and their families. Typically, when I'm seeing somebody for the first time, I'll ask them if they've got directives in place, like if they've already done a living will or a power of attorney for health care. I generally don't talk to them about what they would want for themselves, or don't probe it in more depth until after I've gotten a chance to know them. It's very tough on an initial visit to begin talking about things you're not going to do to help keep somebody alive, or in the case where they're likely to die. Okay? Yes, ma'am.
George Mulcahy works with cancer patients. Do you have any questions about this? Do you work with this?
I don't know if it's a question or more of an observation. But my observation is that most people prefer not to do this at all, or not to think about it.
Yeah, it's very difficult.
And yet there are some that are very honest and upfront. Go right into it. And still there are others that will come in and when I ask them questions or just a simple question like, have you made a will? And I know the background and circumstances. And they say, no, do you think it's time that I should? So, some people just don't want to handle it.
Yeah.
You have one statement here, and I wanted to ask you about this. The GMR order should be documented in the chart along with a progress note documenting the discussion with the patient and their decision makers. Is it necessary that the discussion be with the patient and the decision maker, or is it patient or the decision maker?
Okay. If the patient is competent, your only requirement is that you talk to the patient and you document the patient's wishes. If the person's incompetent, it's the decision makers that you speak with. I prefer to have both parties there, family and patient, because it's important for the family to be comfortable with the person's decision for themselves and to be able to honor that decision.
Whether they're comfortable or not.
Right. They have to come to terms with it. So again, at least in my practice, my preference is always to, or as often as possible, to make sure that the family and the patient have the same information, and that if the patient's competent, they make the decision for themselves, that the family is aware of the decision, and that there are no big objections. If there's discord within the family, I urge them to talk about this, and once they've reached a consensus, to make a decision. You know, a lot of times, people don't want to make decisions until they've checked off with their family, talked it over with their spouse, but it's important to have that consensus in the family. It makes the care of the person, I think, much more compassionate and much less stressful for the patient and for the family when in fact they're ill. If you don't have these things in place, then especially if the tempo of the illness is moving quickly and things need to be done on an urgent basis, then you're dealing in a crisis mode, and bad and very hard decisions get made under those circumstances.
I agree with you there. I think it's very important for the family to be involved. My personal feeling is that quite often the patient changes his or her mind because of what the family,
Mm-hmm.
and that could even be the youngest child, who recently, a 16-year-old son, said in my presence to the mother of his father at the time, he said, "Grandma, you've had my father for 42 years. I've only had him for 16 years, and I want him around."
Mm-hmm. Well,
So that issue with that family is still up in the air.
right. Well, those things have to get worked through.
The larger the family, the more work.
One of the nice things about a power of attorney for healthcare is that it sort of narrows down the who's got the decision-making authority. And I mean, I've also dealt with large families, and like for example, there'll be the one child who's actually looking after mom and dad in the home, and they're the ones who are bearing the brunt of all the responsibility. And I say, well, what about your brothers and sisters? And he said, it doesn't matter. If they want to take care of, if they want the responsibility of taking care of mom and dad, then they can come take care of them. But until they do that, I'm the one making the decisions.
Mr. Eileen works with Autonomy,
Mm-hmm.
a different part of town, with people who are large Hispanic population. Do you have any experience in working with the Hispanic population on these issues? Do you have any issues to share or questions?
Not particularly that, but I did have a question. You've already kind of answered it when you said people who operate out of a crisis situation. And you were saying, we respect the wishes of the individual. The family member comes and says, I want this for dad, and
Mhm.
whatever, we do what he is requesting. But the individual who has no one, I mean absolutely no one, and someone gets assigned through the court, and maybe it's someone who's a total stranger who wouldn't have known,
Mm-hmm.
but that makes it, I suppose, legal since it is assigned and it becomes a crisis or whatever.
Yeah, you have to, the guardian has to be involved in the decisions. Now, there are also circumstances where you have somebody who is incompetent, and they do not have any family, they do not have any friends, they do not have a guardian. And again, an example I can give you is somebody who was admitted to the VA from a nursing home who literally had no one, and they had a Folstein mini mental status score of 0. They could not answer any single question on mental status testing, and they had a broken hip. They weren't and the question came up: should we fix the hip? And this person was and there was nobody to talk to regarding this man's wishes. And he was unable to really ambulate well. He was requiring a lot of care out in the nursing home. And under those circumstances, the doctor has a responsibility to use their best medical judgment as to what would be helpful for the patient. I saw no benefit for putting this man through any kind of operation to fix his hip. Felt we could manage the pain without doing it, and that he was going to die with this probably. And we sent him back to the nursing home. But I can tell you that the notes that I wrote in that man's chart clearly documented that there was nobody around to help with the decision making, that we made the effort to find somebody who could speak for him in his behalf and be his advocate. And then I made my own, writing that I thought that this would be futile, that it would not impact on his quality of life or care, and that we were making this decision in our best medical judgment. That's the kind of documentation you have to see there.
In response to Ruth's question, I am not in the homes making business, so I'm sure I'll be running into some of these other aspects, and maybe work with families and help them come to some conclusions about those kinds of things.
Right. You do not need an attorney to execute a living will or a power of attorney for health care. You can do this on your own, and it's a legally effective document, as long as you follow the state guidelines for what constitutes a legally effective document. Okay.
Thank you very much.
Thank you very much.